We were discussing acute gastritis, and there are factors which are responsible for acute gastritis, and they are psychological factors. Acute inflammatory changes are seen in emotional conditions of various types. These cases are transitory, but emotional stress of longer duration may produce permanent damage. So, if these psychological changes persist, they can produce permanent damage in the gastric mucosa. Now we are going to discuss briefly stress-related mucosal diseases. Regarding etiology, stress-related mucosal diseases can be caused by severe trauma, extensive burns, increased intracranial pressure, or diseases which produce or intracranial diseases, and then the stress of the surgery or extensive surgery. Now, the stress ulcers are produced due to shock, due to sepsis, and due to trauma. Curling ulcers. These ulcers are seen in the proximal duodenum. These ulcers are seen in the proximal duodenum, seen after severe burns and trauma. Cushing ulcers, commonest sites are in the stomach, they are gastric, but can be seen in the duodenum, in the esophagus, and seen in patients with intracranial disease or injury. There is also direct stimulation of vagal nuclei resulting in hypersecretion of the gastric acid. Very important. Direct stimulation of the vagal nuclei which results in the hypersecretion of the gastric acid. And they are important because there is high risk of perforation. Pathogenesis, most important, is local ischemia or due to systemic hypotension. Then stress-induced splanchnic vasoconstriction, increased release of vasoconstrictor endothelin 1, which contributes to gastric mucosal ischemic injury. So these are the important points. The most important is the local ischemia, and then due to systemic hypotension, or there is stress induced splanchnic vasoconstriction. Now I repeat, pathogenesis, local ischemia due to systemic hypotension, stress induced splanchnic vasoconstriction, and there is release of vasoconstrictor endothelin 1, which contributes to gastric mucosal ischemic injury. Now, morphology, initially they are shallow erosions, but once ulcers are produced, these ulcers are rounded in shape. These ulcers are rounded in shape, less than 1 centimeter in size, less than 1 centimeter in diameter. The base of the ulcer appears brown to black by acid digestion of blood. As we know that when there is an ulcer, the blood vessels they leak, blood is going to come out, acid is present in the gastric juice, and that blood is digested or degraded and it imparts brown to black coloration to the ulcer base. Acute stress ulcers, very important point, they are multiple and can be found anywhere in the stomach. So they can be seen anywhere in the stomach. They are multiple and can be seen anywhere in the stomach. Microscopic features. These ulcers are sharply demarcated ulcers and they have normal adjacent mucosa. Serositis may be present. Mostly, the healing is complete with reepithelialization. Healing is complete because reepithelialization takes place, and it takes few days to weeks to completely heal the ulcer after treating the underlying cause. Chronic gastritis. What is chronic gastritis? It is chronic mucosal inflammatory changes leading to mucosal atrophy and epithelial metaplasia without erosions usually. So I repeat, the definition is chronic mucosal inflammatory changes which leads to mucosal atrophy, and then there is epithelial metaplasia usually without erosions. Now, what causes chronic gastritis? Of course, we have been discussing that while discussing acute gastritis. When there is an imbalance between the damaging forces and the mechanism which are responsible for the defense system, then gastritis occurs. So, increased damage or impaired defenses, they are responsible. Similarly, then there is shock, ischemia, shock, non-steroidal anti-inflammatory drugs. Causes are very important. Most important is h.Pylori infection, non-steroidal anti-inflammatory drugs, smoking, alcohol, increased gastric acidity, duodenal gastric reflux. Etiology of chronic gastritis, chronic H. pylori infection, autoimmune disorders or autoimmune gastritis, alcohol, smoking, bile reflux, obstruction, radiation, graft versus host disease, and Crohn's disease. There are many other, but the important one are these. Now, gross and microscopic features of chronic gastritis. Mucosa appear red, texture is coarse. Initially, there are thickened mucosal fold followed by flattening of gastric mucosa, and then there is infiltrate of lymphocytes and plasma cells in the lamina propria. Now you can well appreciate in this photograph or microphotograph that there is chronic inflammatory cellular infiltrate in the lamina propria of the gastric mucosa. Chronic superficial gastritis is limited to the upper third of the mucosa, but in severe cases, inflammatory infiltrate is seen in the full thickness of the mucosa, and lymphoid follicles they are present, and they are also having prominent germinal centers. Now there is another term which is chronic atrophic gastritis. In prolonged cases, there is loss of glandular structures associated with flattening of the mucosa. We call it as chronic atrophic gastritis. Loss of glandular structures which is associated with flattening of the mucosa. And then there is replacement of the gastric type of mucosa by intestinal type of mucosa, which is called intestinal metaplasia, and this is seen in patchy manner. This is seen in patchy manner. Gastric atrophy is when return to normal morphology is not possible. We use the term that there is gastric atrophy because when the morphology does not return to normal and the specialized gastric cells are completely destroyed, and there is increased risk of gastric carcinoma. Now you can well appreciate in this is a case of chronic gastritis in a microphotograph, and there is, you can well appreciate here that there is, these are the intestinal metaplasia. You can see that intestinal epithelium with goblet cells. Another photograph or hyper view pointed by the arrows, you can appreciate these intestinal metaplasia in chronic gastritis. Now we are discussing chronic gastritis. There are three main patterns of chronic gastritis. One, Helicobacter associated gastritis. Two, autoimmune chronic gastritis. Three, reactive gastritis. So three main patterns of chronic gastritis: Helicobacter associated gastritis, autoimmune chronic gastritis, and reactive gastritis. Before going into the detail of each of them, we must discuss pathogenesis of h.Pylori. Pathogenesis of Helicobacter pylori or h.Pylori. They are gram-negative, spiral-shaped organisms. They are motile, having 4 to 6 flagella. The organism can colonize the epithelial cells of the stomach and duodenum, and they are transmitted through oral to oral or oral to fecal routes. Bad sanitation is a very important factor, and its incidence is higher in those countries where there is overcrowding, the sanitary conditions are bad, the food and water is unclean. Commonly, these organisms are found in the deeper portion of the mucosal gel, coating the gastric mucosa or between the mucus layer and the gastric epithelium. So I repeat once again that these organisms are found in the deeper portion of the mucus gel coating the gastric mucosa or between the mucus layer and the gastric epithelium. I'll show you the photographs. These organisms may attach to gastric epithelium, but under normal circumstances, very important point, these organisms attach to gastric epithelium, but under normal circumstances do not appear to invade the cells. So let's discuss it. This is the flagella. Bacterial motility depends on these flagella, and they allow the bacteria to remain motile in viscous mucus to colonize later on. Ureas. What are the various components in it and their importance? It produces ureas which neutralize gastric acid. It produces ureas which neutralize gastric acid. How it neutralizes the pH of gastric acid? Because there is urea present in the fluid of the stomach. So this urease break that urea, with the result local gastric pH is elevated. Local gastric pH is elevated. Very important point. So bacterial survival is enhanced. Bacterial survival is enhanced. So it produces ureas which neutralize the gastric acid, the pH of gastric acid, by generating ammonia from endogenous urea, and urea is present in the fluid of the stomach. With the result, ureas break down that urea, local gastric pH is elevated. With the result, bacterial survival is enhanced. Although it can survive very harsh pH of acidity of stomach, but the organism prefers to remain living in the pH which is elevated. So it is mostly found in the gastric antral. Now it has a lipopolysaccharide. This is one marked with arrow. Outer polysaccharides, and by the help of this lipopolysaccharides, this bacteria attaches to the host cell, and also these lipopolysaccharides also act as endotoxins and are responsible for inflammation. Now then there are outer proteins. These are the outer proteins, very much marked. They are adhesins, and they help the bacteria for the attachment to the surface of the host cells, mostly foveolar cells. Then there are exotoxins, and here they show their exotoxins, and they are VAC or vacuolation toxin A. These vacuolation toxin A, they are secreted by h.Pylori, and they assembles in such a way that when they come in contact with the host cell membrane, they sort of form selective ion channels or selective anion channels that classically define VAC-A as a pore-forming toxins. So it is responsible for gastric mucosal injury by vacuolating the cells, and I have explained it how it forms that vacuolation by means of assembly of selective anions channels that ultimately define VAC-A as a pore forming toxin. Of course, I don't want to go into the detail of that. They assemble into form oligomers, and then they form these oligomers, they assemble into selective anion channels. I just don't want to, but if you just remember that, I think it's more than sufficient that these exotoxins, they are forming vacuolation toxins, that is VAC-A, and they are causing mucosal injury by vacuolating the cells, or this VAC-A is known as also act as a pore forming toxin. Now there are many other secretory enzymes which are responsible for the injury to the gastric mucosa. There are mucinase, proteases, lipases. They all cause gastric mucosal injury. Then a very important feature of it produces CAG-A, and that is virulence factor of h.Pylori, which is cytotoxic associated gene A, and it's responsible for actin remodeling, interleukin 8 induction, host cell growth, and apoptosis inhibition. Now this CAG-A is associated with pathogenicity islands, which are called CAG PAI, that is pathogenicity associated islands, and they are injecting these CAG-A toxins into the host cells through type 4 secretory system. Basically, it's also known as T4SS, type 4 secretory system. This is type 4 secretory system, and there is pili-like structures which inject these effectors into the host cells. And if you ask me what is type 4 secretory system, it's a system by which the bacteria is able to transport proteins and DNA across the cell membranes. I repeat, secretion protein complex which enables the bacteria to transport proteins and DNA across cell membranes. This is type 4 secretion system, or briefly T4SS, as we have discussed. Now this is very important, CAG-A gene positive h.Pylori, because CAG-A gene positive h.Pylori show increased prevalence of gastric carcinoma. The incidence, those h.Pylori which express CAG-A gene in their infection, the incidence of gastric carcinoma is increased. These strains, when colonize the gastric body, now how they produce gastric carcinoma? Because when they colonize the gastric body, they produce or they induce pro-inflammatory cytokine secretion. Ultimately, there is atrophy of the gastric mucosa and intestinal metaplasia more effective. So, those H. pylori which express CAG-A gene, they show high incidence of gastric carcinoma than those which do not express CAG-A gene or they are CAG-A gene negative, because these strains, that is CAG-A gene positive strains, when colonize the gastric body, they induce pro-inflammatory cytokine secretions, atrophy of the gastric mucosa, and intestinal metaplasia more effectively. Now, similarly, at the same time, host cells shows increased expression of tumor necrosis factor and interleukin 1 beta, which are pro-inflammatory cytokines. So host also produce a response, and also host produce decrease expression of interleukin 10. So I repeat briefly that CAG-A is an important toxin or CAG-A gene, cytotoxin associated gene A, which is a virulence factor for H. pylori, and it has been seen that those H. pylori which express CAG-A, they develop more frequently. There is more association of, or there is high incidence of gastric adenocarcinoma than those which do not express CAG-A. Then there are other points, like once they colonize the mucosal cells, they produce pro-inflammatory cytokines, and ultimately they are responsible for atrophy, they are responsible for intestinal metaplasia, and ultimately gastric carcinoma. Host also produces certain factors, and that is increased expression of tumor necrosis factor and interleukin 1 beta, which are pro-inflammatory cytokines. And also the host is expressing anti-inflammatory cytokines interleukin 10. Their expression is decreased. So decreased expression of the anti-inflammatory cytokine, please note it down, that the inflammatory cytokine interleukin 10, their expression is decreased. So this leads to pangastritis, gastric atrophy, intestinal metaplasia, and gastric carcinoma. So the course of the, very simple, by all these features, we can say that the course of the H. pylori depends upon bacterial three things: virulence factors of the bacteria, bacterial virulence factors, immune response of the host, and also gastroduodenal mucosal defense of the body. Now, if we sum up the role of the H. pylori, these H. pylori They pass through the gastric, they survive the gastric acidity of the gastric juice or gastric fluid, they survive the acidity of the gastric fluid, moves with flagella, pass through the mucus layer, come in contact with the epithelial cells of the gastric mucosa. Gastric, gastric. Right? So this is the, let's suppose this is the h.Pylori. So passes through the acidity of the gastric juice, pass through the mucus layer, which is viscous mucus layer, with the help of the flagella, and then they come and attach themselves to the epithelial cells. They have got two adhesive molecules, BAB and SAB. Okay, this we have discussed. So they're going to attach to these. This is the epithelial cells. So this is the H. pylori, the green one. Pylori. They have BAB and SAB. Okay. Now these BAB and SAB, they come and attach themselves to Lewis B and Lewis X, which are the sites for their attachment on the gastric epithelial cells. Then what happens? As I told you, that this H. pylori is now producing urease. It is producing, you can say that it is producing urease. This is, urease is being produced. There is urea present in the stomach fluid. This is the formula of the urea. This is urea. And this urease breaks down this urea which is present. Ultimately, carbon dioxide and ammonia is produced. And that ammonia, once produced, it elevates the pH and produce a microenvironment which is suitable for the living of the Helicobacter. We're coming to that. Look at that. The pH is increased. Higher the pH, more and more Helicobacter. This is the microenvironment. So, micro environment and more Helicobacter. These are all Helicobacters. They are coming and they are surviving in that microenvironment and they are attaching themselves to the epithelial cells of the gastric mucosa. So ammonia is produced, mucinase is there, which are enzymes, proteases, lipases, cytotoxin associated gene A, vacuolation, VAC-A or CAG-A, and ultimately they are responsible for producing injury to these cells. Now one thing, literature it's mentioned that the surface of the gastric mucosa is resistant to the acidity of the gastric juice. But these junctions, once they are broken down, the injury becomes more and more severe. So we're coming again that there are three patterns of chronic gastritis: Helicobacter associated gastritis, autoimmune chronic gastritis, and reactive gastritis. We're just repeating the slide because before going into the detail of that, we discussed the mechanism of action of H. pylori and the various features of H. pylori. Now, H. pylori or Helicobacter pylori associated gastritis, most common form of gastritis, arise at any age, and the important thing is antral mucosa is most commonly involved, or it involves the antral mucosa. But once there is dense colonization, H. pylori are present in the mucosa of the fundus and body of the stomach. Now, again, an important thing, I just repeat this for you just to refresh your memory, that it's a common form of gastritis seen at any age. It involves antral mucosa much more commonly, but once there is dense colonization, fundus and the body of stomach, they are also involved. There is another important feature in it. There are areas of heavy colonization followed by few organisms, and then there are other areas of heavy colonization. These H. pylori, they are associated when they are present, when they produce gastritis or gastritis associated with H. pylori, there is associated development of duodenal and gastric ulcers. Much more common are the duodenal ulcers because lying close to the antral. Now what happens? Their favorite site is antral mucosa. So antral mucosa is erythematous. It has a coarse or even nodular appearance. There is dense population of inflammatory plasma cells in the form of clusters or sheets seen within the superficial lamina propria. Please note it down because this is a very important point, because in autoimmune gastritis the pattern of inflammation will be different. So antral mucosa is erythematous. It has coarse or nodular appearance. There is dense population of inflammatory plasma cells in the form of clusters or sheets seen in the superficial lamina propria. There are increased number of lymphocytes, macrophages and neutrophils within the lamina propria. Neutrophils, they accumulate in the lumens of the gastric glands or pits to form, very important point, pit abscesses. Antral mucosa is erythematous. It has coarse or even nodular appearance. There is dense population of inflammatory plasma cells in the form of clusters or sheets within the superficial lamina propria. Please note it down, within the superficial lamina propria. Differentiating point. Increased number of lymphocytes, macrophages, neutrophils are also present within the lamina propria, and then the neutrophils, they accumulate in the lumen of the gastric glands and pits results in the formation of pit abscesses. Now here you can see that these are the intraepithelial, this is the lamina propria, the cells, this is the superficial area, and that contains neutrophils, and also intraepithelial presence of neutrophils, a very important point in H. pylori associated gastritis. Diagnosis: urea breath test, well, fecal bacterial detection, antibodies to H. pylori, and PCR based detection of H. pylori DNA. These are the tests, but the gold standard test is antral biopsy. And in antral biopsy, a very important vital question: how you can demonstrate that? From where you take the biopsy? Of course, antral is the most common site to take the biopsy, and then you can find these organisms on H&E staining. You can find these organisms, or you can demonstrate these organisms on Giemsa staining, and you can also demonstrate these organisms on silver staining. I'll show you the photograph for that. This is the H&E staining, and you can appreciate this is a rather low power view, and you can appreciate there are bacilli which are slightly basophilic. H&E staining showing there are H. pylori. Here H. pylori are more marked, right, having a basophilic appearance. Then Giemsa stain, you can very well appreciate, no doubt about it, H. pylori present. And then this is Warden starry silver stain. Please remember the name. If you don't remember the full name, at least you should remember a silver stain. We can demonstrate these organisms on silver staining, but it's better to remember Warden starry silver stain, in which they are spiral shaped black organism. You demonstrate H. pylori as spiral shaped black. Whenever there is a word silver, whatever it's going to demonstrate, it's going to come black. So Warden starry silver stain. Well, it can lead to, that is, H. pylori associated gastritis can lead to chronic gastritis or chronic active gastritis, peptic ulcer disease, that is duodenal ulcer or gastric ulcer, or gastric lymphoma. So two malignancies are important if examiner asks you. One is lymphoma and other is adenocarcinoma. Now we discuss another topic, which is autoimmune gastritis. This autoimmune gastritis seen in elderly patients in whom severe gastric atrophy of the mucosa has developed. We call it as type A gastritis, and it's easy to remember. Type B gastritis is H. pylori associated gastritis, since H. pylori are bacillus, so B stands for bacillus and B stands for type B, and then autoimmune, A stands for autoimmune and A stands for type A. So try to remember like that. Now, H. pylori associated gastritis was more in the gastric antrum. But here, autoimmune gastritis involves the gastric body and the fundus. Autoantibodies to parietal cells are seen in 90% of cases. Intrinsic factor is seen in 60% of cases, with the result once there are autoantibodies to parietal cells are present, there is loss of parietal cells. So once there is loss of parietal cells, there is decreased production of acid, and also there is decreased production of intrinsic factor. Reduced serum pepsinogen 1 concentration, endocrine cell hyperplasia. Now it's very obvious that once parietal cells autoantibodies are present for the parietal cells they are going to be destroyed, or you can say they undergo atrophic changes. So with the result there is loss of production of HCl. With the result there is increased levels of serum gastrin. Now since it is an autoimmune disease, more common in women than in men, and as I stress again that autoimmune diseases, they are always in association. So there is another associated autoimmune disease. It can be diabetes mellitus type 1, or it can be the chronic thyroiditis or Addison's disease. They are associated with autoimmune gastritis. So autoimmune damage to the gastric cell leads to reduced production of hydrochloric acid and failure to absorb dietary vitamin B12, resulting in pernicious anemia. Now, pathogenesis, autoimmune atrophic gastritis, because once there is autoantibodies are formed, they just attack the parietal cells and ultimately leads to autoimmune atrophic gastritis with the loss of parietal cells and loss of HCl production and decreased availability of intrinsic factor. Now, absence of acid production stimulates gastrin release. Very simple. HCl reduce, HCl goes down, gastrin release goes up, with the result hyperplasia of the antral gastrin producing G cells is present. There is associated intestinal metaplasia, which led to the term autoimmune, a term which is used for it, autoimmune metaplastic atrophic gastritis. CD4 T cells directed against parietal cell components. Another important point to note. So, autoimmune atrophic gastritis associated with the loss of parietal cells, with the result decreased HCl, reduced intrinsic factor, decreased HCl, increased gastrin level, and also there is increased, or there is hyperplasia of antral gastrin producing G cells. There is associated intestinal metaplasia, which has led to the term autoimmune metaplastic atrophic gastritis. Otherwise, it is autoimmune atrophic gastritis. Very simple. Once intestinal metaplasia takes place, we call it as autoimmune metaplastic atrophic gastritis. And CD4 T cells directed against the parietal cell components. In autoimmune atrophic gastritis, there is diffuse damage to the oxalic acid producing mucosal cells, which are seen in the body and the fundus. The antrum and the cardia are spared, with diffuse atrophy Mucosa of the body and fundus appears markedly thin. Rugal folds are lost. When there is thinning, of course, it's very simple that there is the rugal folds of the mucosa, they are lost. Neutrophils may be seen, but the inflammatory cell infiltrate is mainly composed of lymphocytes, macrophages, and plasma cells. Lymphoid aggregates and follicles may be present. In autoimmune atrophic gastritis, differentiating point. In autoimmune atrophic gastritis, inflammation is deeper and centered on the glands, whereas it was in the superficial lamina propria in case of h.Pylori induced gastritis. Now it's very simple. When you imagine the uh, morphology of the gastric mucosa and there are folds in it, but once the atrophy is incomplete, there are residual islands of acid producing cells and they stand out or they appear as multiple small polyps. Very important. They're not true polyps, but they appear as small polyps because there is patchy atrophy, and in between there are islands of oxygenetic cells and of the mucosa. They stand out and they appear as small multiple polyps. Clinical features are mostly due to deficiency of vitamin B12 because intrinsic factor is not there. So the features, they are just like that of are those which are seen in vitamin B12 deficiency. There is megaloblastic anemia, or atrophic glossitis, and the tongue becomes smooth and beefy red, malabsorption diarrhea, and CNS manifestations. Now, a few words about reactive gastritis, also known as reflux gastritis. It takes place or it occurs when alkaline duodenal fluid containing bile refluxes into the lower part of the stomach. That alkaline duodenal fluid which contains bile that comes up in the lower part of the stomach, and also seen in patients with previous gastric surgery of the pyloric region causing incompetency of pyloric sphincter. So after surgery, the pyloric sphincter is not very competent to contract properly, with the result the duodenal contents which are alkaline in nature and containing bile, they reflux into the lower part of the stomach. This condition is also seen in patients on non-steroidal anti-inflammatory drugs, and they directly cause damage to the mucus layer. Now I have briefly discussed the subject with you. If you have any question or any difficulty or any clarification, kindly do write in the comment box and inshallah I'll answer it.